Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. It's my pleasure to serve as the host of the CGNE Seminar Series. As we launch our fall semester series, I'd first like to take an opportunity to thank Amy Caputo, CGNE Marketing Communications Specialist, for all of her efforts in advertising our center's signature education program. I'd also like to thank Jenny Rank, our education program specialist, for her work related to contact hours and for helping to implement the sessions. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, We Are in Pain, a program of inclusive research on osteoarthritis pain in African American older adults, will be presented by Dr. Stasia Starr Booker from the College of Nursing, University of Florida. Before we begin the presentation, we do have some disclosures and announcements to make. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. We do want participants to know that we are recording the seminar. And if you have any questions or comments for our speaker, you can do this a couple ways. You can enter it into the chat feature, or you can raise your hand and Jenny will unmute you so you can speak aloud. We do encourage your participation, so please feel free to share comments and questions. We do have a post-event evaluation, and the link will show in your browser when the seminar concludes. So when the Zoom link ends, it'll pop up on your browser. It will also be emailed to you within 24 hours. If you're an RN and you would like to have contact hours for this session, completing the evaluation is required, but we do ask that all attendees complete the evaluation to assist with our data collection, but to also give us feedback on the seminar. So again, for RNs, to earn contact hours, we do record Zoom in and out times for attendance. We do require that you complete the evaluation, and that has to be done within a week of the seminar. You will receive, if you've met these requirements, you'll receive a certificate within a month of the seminar. And if you have any questions at all, you can always reach out to cgne@psu.edu. Next, I'd like to introduce Aza Al-Hasari, one of our PhD student affiliates. Aza participates in various learning opportunities with our center, such as our Gero Rig series. She's also volunteered to analyze data for our impact report and assist with spring brunch activities. Aza is a wonderful addition to our center, and we really appreciate that she will be introducing our speaker today.
Thank you, Janice. It's my pleasure. So Dr. Starr Booker is an assistant professor of nursing at the University of Florida College of Nursing. Dr. Booker is well known for her research on disparities, injustice, and health equity in the field of pain. For over 10 years, Starr's research has illuminated the lived experiences and management of chronic pain in older adults, particularly those who identify as African American Black. She has completed several research projects funded by the NIH. Her most recent studies investigated biopsychosocial behavioral predictors of movement-evoked pain in older African American Black with knee osteoarthritis. Dr. Booker loves to use her voice and expertise through writing. In 2022, she was one of the 10 faculty from across the University of Florida who received the Excellence Award for Assistant Professor, the first time that a College of Nursing faculty has received this award. For her commitment to diversity and inclusion in research and mentoring, Star was honored with the UF College of Nursing Inaugural Diversity and Inclusion Award in 2021. Dr. Booker is active in several organizations, the U.S. and International Association for the Study of Pain, American Society for Pain Management Nursing, the Gerontological Society of America, and the Florida Nurses Association. Star loves to travel, praise and worth time, and good food. She is a Louisiana girl. So welcome, Dr. Booker.
Thank you.
Thank you.
All right. Okay, slides up. Perfect. Well, thank you all for the invitation to present today. I think it's very fitting that I'm doing this presentation in this month because September is National Pain Awareness Month. And to get us started, little quick interaction here. On the right are some options. And I want you to put in the chat which of these options describe chronic pain. So I'm going to talk about it, chronic pain, the epidemic of chronic pain. Which of the options A through G describe chronic pain? And there could be multiple answers, so let me say that. So it looks like everyone's saying G, 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 G. All right, well, you all are pretty in tune group because G is the correct answer. Chronic pain is an international public health problem. It is a national public health problem. It has been influenced by the national opioid crisis. It is a health disparities issue. It's a human rights concern, but it's also a civil rights matter. And D, E, and F don't get enough attention. And a lot of my work has really been focused on illuminating that chronic pain as a health disparities and an equity issue. So my presentation today is not about disparities and inequities per se, but I will talk about it in terms of some of the findings that I'll share today and how that shapes how we approach caring for older Black Americans with chronic pain. So again, we are essentially one nation under pain, and up to 100 to 120 million Americans report chronic pain, and that's about 1/3 of the US population, and a large proportion of people with chronic pain are older adults. And so to kind of set the stage for this talk, I want to share two quotes by a couple of my research participants that really highlight the pain that many in the Black community are living with. So Mr. Clyde told me, he said, in terms of talking about his arthritis, he said, it's bad, severe. I hurts all the time. The pain never goes away, the inflammation. Well, look at me. I can barely walk. I got the worstest arthritis. And then I had another gentleman tell me, in terms of the work that I do, my research, he says, see, you picked a good subject to work with. And that always encourages me. There's a lot that we need to do in terms of improving the care of older adults who have pain, not just Black Americans, but all older adults. So in this presentation today, as it has been mentioned, I'm talking about we are in pain. It's kind of a play on words because, you know, it's the "we are" chant, you know, for Penn State, and I am a Penn State alum. And so basically, I want to look at the evidence that I've gathered to really support the unequal burden of pain that African American older adults experience. So my program of research broadly seeks to advance the science of pain and aging with an emphasis on racial disparities and health equity. And since I was a master's student at Penn State, I've published about 90 articles, and about 90% of those are related to pain in Blacks or older adults and osteoarthritis. And a major goal of my research is to translate into best practices for greater precision in pain assessment and pain management. And, you know, the literature is compelling and consistent in showing that pain in African Americans is greater. So that means they have a higher intensity, more widespread, more sensitivity to pain, more pain behaviors. But it also leads to greater impairments. So issues with mobility, more or greater disability and morbidity. So how did I get here in terms of my program of research? So in 2019, I participated in a summer research internship through the School of Nursing. We were still a School of Nursing now. I know you all are a College of Nursing. And that program was called McCann, and it was directed by Dr. Lisa Kitco. And so I applied to this program and was accepted. And so I came up to Penn State for 6 weeks. And it was my first time being away from home. But during this time, I was introduced to advanced practice nursing and nursing research. And so I shadowed several research teams that were studying dementia or mild cognitive impairment and long-term care. I think the studies may have been by Dr. Kolanowski and maybe Dr. Fick and Dr. Loeb at the time. And so as part of the program, I had to complete an annotated bibliography and give a short presentation on a topic that I was quickly becoming interested in, which was pain assessment in nonverbal cognitively impaired older adults. And also during this time, I worked with Dr. Kitco on my first published paper, which I'll talk about in the next slide here. So in my sophomore year of nursing school, I wrote a research paper on reducing ventilator-associated pneumonia. And my instructor encouraged me to consider publishing this paper, which I thought was a preposterous idea. First of all, why do I need to publish this? What's the benefit to me? And how long will it take, right? So all these questions. And so when I started the McCann program, I thought about this a little bit more, and I approached Dr. Kitco, who was a former critical care nurse, and I said, and I asked her if she would be willing to help me revise the school paper because I wanted to try to publish it. It took me 3 years to get this paper published. And this paper has nothing to do with pain or African Americans, but it was my entry into scholarship and publication. So fast forward to 2012, now I'm a master's student in the CNS program. And I participated in a 2-week service learning course where we went to South Africa and with a group of undergraduate students. And I can't remember the faculty's name who was the coordinator, but her husband was a physician at Hershey. And so while we were in South Africa, I keenly observed how older adults lived, how they were cared for when we would go to the various hospitals and clinics and community centers and villages. And based on that experience, I was able to publish another paper in a South African journal, comparing the differences between aging in African older adults and African American older adults. So I share this background to show you how these different experiences, learning about gerontology and writing, fueled my passion to study and communicate the experience of pain in diverse older adults. I specifically became more interested in the experience of pain in Black Americans after completing a systematic review for my master's degree scholarly paper. And this was the foundation for my current program of research. And this is the paper that I wrote for my master's program. And then it was later published in the Journal of Transcultural Nursing. So today, I want to share my journey in understanding kind of the full experience of older Blacks living with osteoarthritis, from creating a model of the lived experience to what we know about mechanisms and measurement and management of chronic pain. So this will be a very high-level view. I can't share everything I've learned and everything that I've discovered in my research studies, because I could talk for 3 hours and still not share everything that I've learned. And so again, this is just kind of a very broad hodgepodge presentation, okay? But currently, I've shifted my focus just a bit to really start to disentangle the types of chronic pain that people with osteoarthritis experience. So looking at the differences between rest pain and a phenomenon that we call movement-evoked pain. And so my current work is really devoted to developing the science of movement-evoked pain and chronic musculoskeletal conditions such as OA. So what do we know about pain over time in older Black adults? So this is a paper that was published recently, well, a few years ago. And we use group-based trajectory modeling to identify distinct pain trajectories over 18 months. And then we also did a multinomial logistic regression to examine the associations between sociodemographic characteristics, risk factors in those pain trajectory groups. And one of our findings was that younger, less educated, lower income, and non-Hispanic Black participants with OA had a greater representation in the highest pain trajectory groups. So there were 4 groups: low pain, moderate low pain, moderate high pain, and high pain. And there were more Blacks in the moderate high and the high pain group. But if you look at the table, you'll notice that there are no Blacks categorized in the low group. And that signifies that Black Americans are already starting out at a disadvantage in terms of pain. Now, when you look at white Americans with OA, the majority of those participants are in the low or the moderate low groups. So this is already giving us some indication that there are some differences in pain over time for different racial groups. So in another longitudinal analysis, we used the MIDAS and the HRS national data sets to examine how family relationships convey risk or resilience for the development of pain and then for the persistence of pain over 10 years. And this is in African Americans only. And what we found is that family support and average support were linked to a decreased odds of pain incidence in MIDAS, but only when tested without accounting for strain. Whereas parent-child strain was a risk factor for pain incidence in HRS, as was average strain. So in Black older adults with pain at baseline, family support in the MIDAS and average support in the HRS dataset reduced the odds of pain persisting over the 10 years. So what does this tell us? It tells us that, one, family relationships and support are important in understanding the development and chronicity of pain in Black older adults. And they have differential effects based on if they had pain at baseline or if they didn't have pain. What we didn't really look at was the quality of those relationships, and that would be really, really important, not whether or not they had support or strain, but also the quality of that support. So now let's look at family relationships from a qualitative standpoint. So I looked at data from my dissertation study, and it was, I surveyed 110 African Americans, and then I interviewed 18 of them with in-depth interviews to really understand, how do they live with pain and what is their experience from a cultural and a historical, clinical perspective. And one of the findings that came out of one particular analysis, as it relates to family relationships, is that pain disrupts family social roles and relationships, and that when needs for pain care and support exceed family resources, roles and relationships are disrupted by inappropriate responses. And one of those inappropriate responses is to diminish or dismiss the experience of pain. And we call this putting on, or faking the experience and the intensity of pain. So putting on is a cultural term that's used in the Black community. And it's basically a phenomenon that potentiates the power of pain to disrupt roles and relationships and discourages the family from meeting the expected needs of older African Americans. So if you hear the term someone is putting on, that means they're faking. So older African Americans felt that their family members believed that they were kind of faking or exaggerating their experience of having OA pain. So in another analysis, we focused on African American women with chronic joint pain. And we conceptualized this using the Strong Black Woman schema. And so this qualitative study examined the narratives of 9 rural and urban dwelling Black older women to identify the ways in which they displayed strength while living with chronic osteoarthritis pain. And so her stories parallel the 5 characteristics of the superwoman schema, or the strong Black woman phenomenon. Those 5 characteristics are an obligation to present and personify an image of strength, responsibility to suppress emotional expression, resisting vulnerability or reliance on others, motivation to succeed despite limited access to resources, and prioritizing others' well-being over self-care. So those are the 5 characteristics of a strong Black woman. Well, we identified 2 additional characteristics that are unique to Black women in pain, which is 1, spiritual submission for strength, and 2, code switching from a suffering Black woman to a strong Black woman. But what I want to highlight is characteristic number 5, which is that they tend to prioritize others' well-being over self-care. And I think this may be typical for most women, is that we tend to put others before ourselves. And so despite, having chronic pain, they often prioritize family responsibilities, including caregiving for their grandkids or taking care of their spouses and their household, and just sacrificing for their family. And one woman said, I find myself pushing myself a lot, and this is where my mom was. I'm a lot like her. Just always, I'm in the house, I got the wash, I got to do the dishes, I got to cook, I got 10 things going on at one time. And so you can see here again that there's this dynamic between having pain, but still maintaining your role in the family. And then in another qualitative analysis, we identify that pain is a metapersonal experience, and that suffering and silence and just bearing the pain is a generational issue. So what does this metapersonal experience look like? It's a dynamic interaction between God, self, and others. So the extrapersonal factor is their ability in trusting God as their healer. The intrapersonal factor revolves around the ways in which older African Americans bared or lived or endured the pain. And so they made adjustments to live with that pain as best as they could. The interpersonal experience centered on how they communicated pain with others, like their family and friends, but also the process of seeking professional advice and their interactions with providers. And so the totality of this metapersonal experience is influenced by multiple social determinants, as well as their childhood experiences, their social support network and norms, their current socioeconomic well-being, and historical events. So, to really understand, though, their current lived experience and pain, or this metapersonal experience, we have to step back in time and examine the history of pain and its intergenerational impact. So when we look at this evolution of the perception of pain in African Americans, when we go back to slavery, that was the period of dehumanizing people. So enslaved individuals were treated as property and unhuman, and property can't feel pain. And so that's how they justified some of the torture, the beatings, and all of that, because it was believed that African Americans didn't feel pain. So then we shifted and went into this experimentation period where some physicians wanted to understand pain in the Black body. And so they experimented on enslaved, poor, and intellectually challenged Blacks to see how do Black Americans experience pain, or do they experience pain? So we moved from experimentation to desensitization, where now we believe that Blacks feel less pain and that there's a biological difference, which became the accepted norm, okay? So after we became desensitized, we moved into criminalizing Black Americans. And so when you look at the heroin epidemic, the crack and cocaine epidemic, Black Americans were criminalized for that. But now when we look at the era of fentanyl and opioids, and a lot of these, and a lot of people who are now misusing opioids, it all started typically from some type of painful injury, right? But now in this era of fentanyl and opioids, which primarily has impacted white Americans, now we're focused on harm reduction and rehabilitation. So we went from this criminalized Blacks who have an issue with substances to let's rehabilitate whites who have issues with substances. So we move from criminalization to now let's normalize that Black Americans experience disparities and racism. And we've normalized these health disparities, racism, and blind justification, and these worst outcomes. And so in our attempts to really quantify the magnitude of pain disparities, we often pointed out these racial differences in health outcomes. And, this was, and it still is effective in bringing attention to the unequal burden and inequities for various populations. But I think we've become too comfortable with repeating what we already know about pain disparities. Instead, I believe we should reframe our messaging around the significance, really emphasizing what do these disparities mean and how can we use a community's strengths to change those outcomes. And this is where I would love us to move into liberation, which is where people can live free in their bodies, that they don't experience these worse health outcomes, these worse pain outcomes. Because in many ways, the intergenerational and internalized trauma that we've experienced over the years still keeps Black Americans in bondage, both physically and mentally. So together, this whole evolution of how pain has been characterized and how it's been viewed in Black Americans really shows the history of discrimination from a different perspective. And it really helps us understand that there are it's a lot of work that we need to do, but it's a lot of deep work that we need to do. So here's an example of some of the beliefs about pain that some people still hold today, which is up to 20% of Blacks' nerve. So this was a survey of medical students as well as the public. And up to 20% believe that Blacks' nerve endings are less sensitive than whites. and that up to 58% of Black skin is thicker than whites. And in this study, Black patients were also rated as having lower pain than whites. So these beliefs directly influence care, clinical care, and we see that as undertreatment of pain. So I like to ask the question to my audiences, what if we were equal? What would that look like in terms of pain and pain management? And I've shown this photo in several of my presentations over the last year and a half, and it's a photo of my maternal grandparents picking cotton in the 1920s and 1930s. And what this photo does is it makes me stop and think about the historical impact of pain and how the unjust history of the US is really not that distant for some of us. So in my dissertation interviews, participants also recalled how their relatives modeled this silent suffering, where they never talked about pain or visited a provider about their arthritis. And so here are some historical insights into pain, and I'll read these quotes. So, suffering in silence. She didn't mention it, my grandma. Oh, because she saw it as a weakness. She was dragging everything, dragging that cotton sack with 2 children on it. And basically, he's just really talking about how his grandmother just lived with the pain. She didn't say anything to anybody. She just did what she had to do to provide for her family. Suffering for survival. This is the last quote. African Americans are probably more capable or better able to accept and deal with pain than others because African Americans have had to deal with so many adverse situations all through life, on down through the years. So in 2003, a seminal article was published by Dr. Carmen Green and a group of top pain researchers where basically they exposed the pervasive disparities that racialized and minoritized individuals face, including Black Americans. And in a follow-up paper that was just published last year, she explored the genesis of this unequal burden of pain, recounting the connection between slavery and historical discrimination and pain. I'm going to skip this slide. But what I'm really encouraged about is that there is a historic and national initiative called Believe My Pain that is a partnership with the makers of Advil, Black Health, and the Morehouse School of Medicine. And they are focused on providing resources to really help champion equity or pain equity in Black communities. And so it's being recognized now that pain in African Americans or Black Americans is a major issue, and it deserves more attention and more resources. For the sake of time, I'm going to skip this slide, and I want to talk a little bit about how African Americans describe OA pain and point out some differences, right? So when I asked older Black Americans and older white Americans to describe the sensation of OA pain, there were some notable differences. So African Americans, they use words like burning and tingling and numbness, but none of the white older participants used tingling and numbness. Instead, they used descriptors like a dull ache or pressure or sharp pain. So essentially, I repeated this in a larger study with all African Americans. And in this study, they used terms like aching, throbbing, burning, stabbing, and sharp. And when you think about the terms that African Americans are using, they're often terms that are also associated with neuropathic pain symptoms. And so we examined neuropathic trends in Black and whites with knee-OA and found that people with a higher mean intensity of movement-evoked pain were more likely to have neuropathic pain symptoms compared to those without neuropathic pain. And guess who was more likely to be in the neuropathic pain group? Black participants. So this tells us that Black older adults with knee-OA may have more neuropathic pathology and central sensitization, which is where your nervous system, your central nervous system undergoes these structural and functional and chemical changes that make it more sensitive to pain. So when trying to understand pain sensitivity and central sensitization due to pain facilitation, I wanted to kind of test this theory about how pain-inducing activities or movement could produce temporal summation. So we had participants use this biodex denometer, and it measured different aspects of knee performance during flexion and extension. And so in the first repetition at 90 degrees, which provides a greater resistance during the kicks, we observed between black and whites that the pain doesn't decrease at the same rate as whites, and that it plateaus in blacks, but it continues to decrease post-movement in whites. And I believe this is related to an inability to inhibit pain and due to central sensitization. In the second repetition, which is the 180 degrees, so the figure on the right, post-movement, pain decreased in both groups, but then you notice that it starts to increase in blacks at 1 minute post-movement. So we see some differences in how pain is inhibited and facilitated in black and white older adults. And so I became interested then in understanding, well, how does pain sensitivity, how is it associated with self-management? So the things that people do to manage their pain. And what we found is that pain sensitivity, as measured by quantitative sensory testing, is differentially associated with self-management in Black Americans and white Americans. And so for Black Americans, it was localized and generalized hyperalgesia and passive coping that predicted self-management use. Whereas for whites, it was the number of body sites that predicted greater self-management use. And so what's really interesting and important for management is that when self-management and medical interventions were used together, Black Americans demonstrated a higher tolerance to pain. So this suggests that a multimodal pain approach is needed to reduce pain at a biological level for Blacks. So I was also curious as to, are there differences in the types of strategies that Black and white older adults use to manage pain? And there are. So Blacks tend to use topical creams, heat, and prayer. And whites tend to use ice, massage, and vitamin D. And they both use over-the-counter medications, because who doesn't want a pill to get rid of your pain quickly, right? So my conclusion, though, is that racial differences in OA pain self-management strategies are likely due to self-management literacy, financial ability, cultural traditions, and basically people are just doing what works for them. And so because prayer was one of the strategies that Black Americans use, I wanted to then look to see how many people are using prayer across 3 different studies. And you'll see that it ranged from 42% in one study to 100% and 90% in 2 subsequent studies. And so we see that prayer is a major pain self-management strategy for African Americans. And I'm now testing an intervention that includes prayer in my RO1 study. So just want to point out here are a few articles that I've published really talking about how do you deliver culturally responsive pain care to Black Americans and providing guidance to nurses on how to care for older patients, Black older patients with pain. And one of the ways I think that we can really begin to create and embed equity into pain care is through what I am terming pain affirming care, which is an empathy-driven and personalized approach that integrates evidence-based care, principles of equity and intersectionality, and proactive population health and preventative measures to ensure that patients in the fullness of their identity, personhood, receive the best and most just pain care. So as part of my program of research, really helping to kind of advance pain management and pain care and pain science. Really involved in a lot of different efforts to enhance equity in research, pain research, to enhance transparency in reporting pain research, and to decrease racism or discrimination in pain research. And so all of that is really important in helping us be able to care for older Black Americans with pain, right? So we have to think about how do we restructure our pain methodologies, our research methodologies, so that we can solicit the best data to understand their experience and use that and translate that into better pain care practices. So as I conclude, I want to share why I titled my presentation, "We Are in Pain." Well, I am a part of the we, not simply because of my racialized identity as an African American, but because I am Black and I also live with chronic pain. And so I recently published an op-ed sharing my personal experience of developing chronic pain and not getting the care that I expected to receive. And so in this op-ed, I'm really advocating for pain-affirming care and for more equitable systems of acute and community-based pain care for Black adults suffering with pain. And I provided the link there if you want to take a read, because a lot of the things that my participants were telling me about their experience, I now also have that same experience. And so it really helps me in my own research to really better conceptualize and empower people, because I understand now what they're going through. So effective pain management is a moral imperative, it's a professional responsibility, and it's the duty of people in the healing professions, which includes nursing. I want you to remember that it is a human right, it's a civil right, and it is a patient's right to have good pain care. And with that, I will stop. I would love to answer questions and have some dialogue with you all. And again, this is just a small smattering of my research. And so thank you.
Well, Star, thank you for that outstanding presentation. That was so interesting. I mean, I'm very fascinated by, the depth of the work that you've been doing in this area. And I really appreciate that you shared your journey as a scholar, because it really helped to understand, why you do the work you do. You're certainly very passionate about it. So it was great to hear about your background, as well as all of your expertise in research and working with older adults, and in particular, African American older adults as it relates to pain. One of the things I wanted to, I'm encouraging the audience to put some messages in the chat. We do have some very nice comments. Wonderful presentation, excellent, thank you. And yep, you saw the comment from Dr. Darlene Clark about Beth Bates being the faculty member that you were referring to early in your presentation. But one of the things I'm curious about is that you were talking about the survey that was done. Well, you did a lot of surveying and interviewing, but the one in particular of medical students and community members that was working to identify their kind of awarenesses or insights or thoughts. It certainly seemed like there were some maybe misconceptions and maybe even myths related to what they thought about Black older adults in pain. The two highlights you shared were that Black older adults are less sensitive, or have their nerve endings are less sensitive, so therefore they don't feel pain as intensely, and that their skin is thicker. that just is, just struck me that, there's that type of misunderstanding out there. And you then also talked about this national initiative to to help people to do some advocating around that. Can you talk about that a little bit more for us? What kinds of strategies are you and others that are involved in this, doing to help change mindsets, for people?
Mhm. So the survey was not one that I conducted.
Okay.
It's one that was published a few years ago. And I use that to highlight kind of these lingering, like you said, misconceptions. It's really a lot of misinformation.
Mhm.
And one of the ways that I am advocating for changing how we approach research and data collection is using kind of this 4M's framework. And I don't have it in front of me, but it's missed information, missing information, misinformation, and the missingness of information. Because again, there are so many misconceptions about the pain experience in Blacks that we still have to counter. In terms of that initiative, it's a national initiative. I'm not involved in that initiative. I would love to be involved. But it really is spotlighting the barriers and challenges that African Americans are experiencing today in terms of getting the care that they need, and really countering kind of those social determinants that are limiting their ability to access treatment. So that particular initiative, it's providing stories about people's experiences, providing resources for patients and providers. So they're doing a lot of things to really champion pain equity, and kind of the first national campaigns that I've ever seen geared towards addressing this major issue.
Yeah, well, thank you for expanding on that. That's really interesting to know about. And certainly there could be others that want to participate or learn more about that initiative. So thank you for sharing that. I'm wondering a little bit about, those misconceptions that, even medical or potentially nursing students might have from an educational perspective. What types of implications do you think, what kinds of recommendations even would you have for nursing, medical schools, or other entities that are trying to promote improved pain assessment, management, and so forth?
Yeah, that's a major barrier, because I think a lot of this could be corrected in medical education, nursing education, any health professions curriculum. And so I'll give you an example of something that one of my participants shared with me, and I had never thought about it. And I was asking about, well, how could, providers or even nurses, how could we help you better manage your pain? And how could we help providers really understand your experience and what you're going through? And one person said, have an empathy simulation. Empathy simulation, how do you do that? And essentially, simulation is a big part of education now. We can simulate a lot of different things. Why couldn't we simulate a scenario where there's a patient and a provider who has to do a comprehensive pain assessment, but there also be some different criteria for that student to demonstrate empathy and understanding during that process. And so, again, I think we have to approach this from a lot of different ways. We have to make sure that even the pain curricula that are offered here in the US, but also internationally, that it is up to date. I served on I was a faculty for the international pain curriculum in Europe. And so, of course, I added information about, understanding cultural differences and understanding disparities and equity, because a lot of that is not included in pain curricula. So there are a lot of different ways and avenues which we have to tackle this problem, including education, making sure that instructors have the most current evidence-based knowledge of how to care for people in pain, not just Black people, but just patients, period. And also making sure that chapters in our textbooks don't perpetuate those misconceptions about pain. I've seen that in a couple of textbooks. So yeah, we have a lot of work to do.
Those are great ideas, great thoughts. Any way to explore potential biases, because I think as human beings, we all have them, but it's so important to be aware of what they are and be able to, shift those, and certainly to provide as equitable of care as we can. Sarah Songer, who is one of our nursing alum, says she wants to thank you so much for explaining about coworkers who insisted on coming to work or doing pain in work or working in pain. So you're kind of acknowledging some of that experience that she had, where she witnessed coworkers that were experiencing pain, but still came to work and did work. So. And then Dr. Diane Barish says, thank you so much for sharing your story and research. Do you have any advice for our students who are working towards their degrees around developing and pursuing their research focus and/or utilizing different research method approaches, both qualitative and quantitative? So I don't know if you want me to separate that into two pieces, or you got it?
Let me tackle the second part, which is utilizing different research methods. This is something that I advocate for a lot, which is to use a mixed methods approach, because there are so many underlying and embedded factors and information that we just cannot get from quantitative research. When you talk to people, you learn more about their experience. With quantitative research, there are so many different there's so much bias that can go into the quantitative data in terms of surveys that will limit someone from being able to really share their full experience. But when you sit and talk to people, they will tell you things that will contextualize sometimes the quantitative data, or it will refute the data, and you have to figure out what's really going on. And so we have to get out of doing research one way. We have
Well,
to.
and you certainly gave some amazing examples of the qualitative analysis that you did. And I would imagine that some of the interviewing you did was pretty comprehensive and took some time, but incredibly valuable.
Incredibly valuable. I have been able to publish 6 or 7 qualitative papers just from my dissertation alone.
I think those are great examples for our students. I want to make sure we get to this next, and we could circle back to the other part of that in a moment, but this next question too. You spoke of the stoic behaviors in Black older adults. In my practice, I have seen many different ethnicities display the same behavior. Have there been any differences noted in the sundry ethnicities regarding stoic personality traits and pain?
Yeah, there are some older papers that came out years and years ago that really look at different cultures and their pain behaviors. I wouldn't say that there's been much research, I would say within the last 20 or 25 years, looking at differences in pain behaviors or cultural differences in that manner. But yeah, there are several ethnicities who display stoic behavior, not just Black Americans. But what I think, in addition to it, displaying a stoic behavior is also for Black Americans, it's been kind of this inability to even communicate with their providers. Really much into this kind of paternalistic patient-provider dynamic. And so not feeling comfortable to be able to speak out, and then when speaking out, not feeling heard.
That's a really important clarification. What someone might be viewing as stoic could actually be an uncomfortableness with communication, or, being able to express what their experience is in an accurate or, comfortable way.
Right.
So, yeah, thank you for that distinction. So, circling back to Diane's first part of her question, do you have any advice? I think this might be a nice way to begin to close our session, but do you have any advice for our students who are working towards their degrees around developing and pursuing their research focus?
I'm assuming maybe is this graduate students or?
We do have several graduate students participating in the session today, so.
Okay, well, I see it coming from Ashley Clark. Ashley and I were in the master's program together. So, hey, Ashley, thanks for coming. I guess my advice would be to really identify something that you're passionate about and use that as your motivation for change. So for me, it was a number of different events that really helped me identify that research was something that I was even interested in, right? So when you have the opportunity to participate on a research team or do a research internship, or anything that's going to give you that research experience, I would say do that, because that will help you understand if research is something that you're truly interested in. And then reach out to people who are doing research in the area that you're passionate in, right? So for me, as a master's student, I was becoming interested in pain. At the time, there was no one at Penn State who was doing pain in older adults. So I reached out to a national expert, Dr. Keela Hurd, which was at the University of Iowa, because I wanted to get more experience and knowledge about pain in older adults. So, think about expanding your network, finding something that you're passionate about, and then finding someone who can mentor you. And one last thought, in terms of research methods, community engaged research is so important, especially for marginalized and disadvantaged populations, and really understanding their experience. So that would be my other kind of thing in terms of research methods. Do community engaged work if you can.
Those are all fabulous recommendations. So thank you for sharing that with everyone that was participating today, and hopefully we can share it with others as well. Just as we wrap up, wanted to share a few additional positive comments with you. Empathy simulation, that would be amazing. Thank you for such an insightful and educational presentation. It's great to see how your expertise has evolved. Thank you so much for this presentation, such an important topic in research, and your determination is evident and will truly benefit so many. So thank you to for your contribution to nursing knowledge as well. But we could do a "We Are" chant if we had everyone on live, but thank you so much, Star, for returning to Penn State to provide this seminar. It's great to have you as a collaborator, and thanks for returning to share your expertise with us. It was a fascinating presentation, and kudos to you on this amazing work that you're doing.
Thank you so much. And I hope to see some of you at AAN. I'm being inducted as a fellow this year, so I'm really excited.
Congratulations on that and the other awards that were mentioned in your bio. So you're a rock star.
Oh, thank you.
All right. Have a great day, everyone, and we look forward to seeing you at our next seminar.